Okay, and that brings us to the last thing, which was
RSI.
the tweak, right? The revamp of RSI, and we previously had that in, and we used succinylcholine, and we used etomidate as our paralytic and our induction agent in that protocol. And then you showed up on the scene, and you're like, there might be a better way. What's the change, and what's the rationale behind why we're retuning this?
So my thought was that the superior way for RSI in the field would be using ketamine as the induction agent to sedate the patient, and then using rocuronium as the paralytic. And I'll kind of go at both of them separately. So from an induction agent standpoint, etomidate is still pretty good. And I use it regularly in the emergency department, but ketamine is potentially better because there is some of the side effects of ketamine is it can raise your blood pressure and raise your heart rate, which can be good in the more shocky patient that you need to
almost
intubate.
Supportive, yeah.
And then on top of that, we can use it to sedate the patient afterwards. So you can give ketamine every 20 minutes at the same dose as you gave for an induction agent, which in our system is going to be 1 milligram per kilogram on average, to then sedate them every 20 minutes at the hospital. We don't use etomidate like that. So if you gave them etomidate as an induction agent, you now have to switch over to ketamine. And this just simplifies things. It's one drug to induce, another drug to sedate afterwards, which makes life a lot easier. And then the dosing is the same.
And then just keep going.
Exactly. and you could get, I use that regularly in the emergency department when I'm just trying to buy some time to get whatever other sedative on board. I will redose the ketamine every 20 minutes
You're
or so.
also getting some other effects with ketamine that you're lacking with the etomidate.
Right.
Analgesia being primary here.
Exactly.
Going to knock out the respiratory drive, which is also nice.
Which he's about to do.
He's about to do
correct.
But yeah, and let's. I think we talked a fair amount about the ketamine awake with Don. So let's Dr. Spanner, we'll sidestep that. And this is strictly RSI piece of this. Then we introduce a little bit different.
Of a paralytic. Yeah, so when in the emergency department, we regularly use succinylcholine and rocuronium. Rocuronium is kind of an intermediate duration paralytic, so it does last a little bit longer than succinylcholine, but it offers a lot of other benefits in the pre-hospital setting where we have very limited information, which is why a lot of us believe it's superior. And so there is a bunch of contraindications to succinylcholine. If you have any concern for hyperkalemia, you can't use it because it's going to raise the potassium a little bit. It goes back down after a period, but the damage could be done. And then there's a lot of other things that kind of deal with having burns for 3 or more days or having other kind of congenital issues. But there is a decent list, and oftentimes when you have a patient who needs to be intubated in the field, you have none of that history.
Don't have that list, right.
And you don't know till it's too late. The benefits of rocuronium is there's one contraindication if you have an allergy to it. Otherwise, you can give it to anyone, and it's totally fine. And so that the benefit is you don't worry about, you don't have to think about those contraindications. You can just give it if you think it's indicated. The negative is that it does last a little bit longer. But the thing is, if you have a patient who needs emergent airway, you need to intubate them because of some reason, whether they're hypoventilating, they're hypoxic despite your best best efforts. You're not going to be able to bag that person through the paralysis of succinylcholine and then have them be totally fine at the end.
Yeah, right.
They're going to be even worse than before you push the paralytic. You got to get that airway one way or the other. And so it doesn't really matter if it lasts a little bit longer. You got to get the airway.
And we're really in my opinion, we're really in a good spot with options when it comes to airways these days. I mean, I remember as a young EMT, as a young paramedic, I didn't show up with an ET tube hanging out of the corner of their mouth. Well, first of all, I didn't have any other options. There was a period of times like I had that, piece of shit combi tube, and I'm pretty sure we hurt more people than we helped with a combi tube. But that aside, we had this whole board behind us here of extraglottic airways and other options. We're really in a good spot from, if that fails, we've got multiple layers of failover that we've really never had before.
Right.
what if we have to fail to the bottom of the list?
Yeah, so I mean that brings up a good
What
point.
if it's a really, really bad
Before we get there, you bring up a good point where you should be planning your backups before you push meds. I mean, so you have to, before you push a paralytic and a sedative to intubate someone, you should have your first, second, and third line options all set up and ready to go. But if you get all the way down, every difficult airway algorithm ends with a surgical airway. If you can't get it with the ET tube, with changing your blade, with using a supraglottic device, if you can't intubate and can't ventilate, you have to get a surgical airway. And some systems use the quick trach, other systems use an open trach. It really just, or not open trach, an open crike. It really is just whatever you've been trained to do, but you have to be ready to do that every time you push a paralytic, because if you can't get the tube and you're not willing to do that, the patient is dead. And so you got to try something.
Yeah, but that is for the case where you are unable to intubate, or let's not say that because that's limiting our because again we have a whole board of other airways here. You're unable to ventilate.
Correct. They have no airway.
Yeah,
you can't do anything.
Nothing's working, right?
Correct.
Because we don't want that to be misconstrued as, hey, you toss that in, it's working fine, but then you should go to the next thing.
This is worst case.
Right.
Absolute worst case scenario. You put the iGel in, you've put the LMA in, you put the King Airway in, whatever you have. Maybe you've tried a combination of those. You cannot ventilate the patient for whatever reason. Then it's cut to air, right? Yeah.
And I do like your thought process earlier off camera. We were talking about this, and you said anybody willing to do RSI better be willing to do that, though.
Correct.
You have to be willing to do that because ultimately, if I can't get an airway, that's where I have to go.
Exactly.
I have to go there.
So your willingness to do things actually ties into who should be doing should be doing RSI. Should every department,
No, and I think that there's
ketamine in the rock and additional ketamine in the box to do this procedure?
Yeah, so it really depends on the individual agency and fire department. I mean, it's great in a situation where you're really far away from the hospital, because that's a situation where they may be, despite your best efforts with BLS skills, hypoventilating, or the patient will be hypoxic and would have benefited from an airway. But you could also be right outside the hospital and still have some benefit of early RSI. And the key is you have to make a decision of what's best for the patient. Even if you can RSI, is pre-hospital RSI going to be better than hospital RSI? Because you want to get the airway in the safest manner possible, and there's benefits to both. And you have to kind of look at every individual situation and look at how long it'll take you to extricate, get the patient to the rig, and then get them to the hospital. And you may be at the top of multiple flights of stairs, and it's going to be impossible to bag them down the stairs. That's a patient where they may benefit from getting pre-hospital RSI, even if you're a block or two away from the hospital, because functionally they're pretty far away.
Sure.
And so it's really looking at each individual situation, looking at how hard the airway is, and putting that all together to pull the trigger on pushing meds and pursuing that. And I've said this to many people, the decision not to intubate is often more important than the decision to intubate. You may know that the patient needs the airway, but saying, I'm going to hold off because I think it'll be better for the patient to get it in the emergency department where they have tons more resources is superior. And that's not a failed airway. That's good decision making in the field and doing what you think is best for that patient.
That's not making you lazy or making you seem right.
Wow. Like we talked earlier, the average time that we commit once we decide or elect to do RSI adds 15 minutes to our on-scene time. So like you said, ultimately, if this is where the patient needs to go, you're okay with adding that time, but you have to be willing to understand that is added time to your on-scene time.
What's the net benefit of that delay? There may be a big net benefit, and so that's why you do it, but there may not be.
Correct. And the other thing we have to remember, and I think that it's very important to mention to the ER receiving, is that if we use the rocuronium, we have to be willing to let you guys know that we're probably going to have to keep this patient sedated. We don't want somebody to wake up paralyzed.
And that's very, if we're using rocuronium and ketamine, the paralytic will last longer than the sedative. And so if you just wait till the patient starts fighting and looking agitated, you've waited way too long. They've been paralyzed and not sedated, which is cruel and inhumane.
That's horrible.
And so you have to, you should be redosing the ketamine after 20 minutes unless there's a reason to do it earlier. So if they're tearing, which patients can still tear despite being paralyzed, or their heart rate is spiking and blood pressure is spiking, they're showing signs that they are very angry with the situation. We want to make sure that they're properly sedated and dosed a little earlier.
And again, you need to front load this situation well beforehand. If this is the first time you've heard the word Bauman Patty, you're not ready for RSI.
Right.
The lemon pneumatic that we can use, the 3-3-2 rule, all of these need to be known. There was checkoff lists we were talking about earlier that some of the helicopter systems are using that it has to be used. You have to go through those boxes, and this is why the 15 minutes is kind of there. Hyperoxygenating this patient prior to intubation attempt. I mean, put them on the nasal cannula running high FiO2 levels, just get them up before we even start. Those critical eight bags before we even consider, that's full inspiration, expiration, full 8 times before we even try for this. Last time we talked with Dr. Spanner, I remember I mentioned one of my things I like to tell the students is that next time you're intubating, hold your breath until you start bagging that patient. And if it's uncomfortable for you, it's been uncomfortable for them. So it's just be ready again to fail and have to move on to something else, and don't have things where they are in the squad. Have them out of the package ready to go, because
everything's sized out.
It's got to be ready.
That's part of the checklist, is making sure you have your backup ready, your backup for your backup. You don't have to open the correct kit or whatever, but just know where it is so that if it's getting really bad, you can just pull it out and go. You don't want to have to think and look around when the patient is crashing.
Yep.
Quick side point to what you were saying is you talked about high flow, nasal cannula under your BVM. If you can't really follow your pulse ox on that, because everybody thinks like, I want to make it 100% pulse ox. Obviously, if it's low, that's bad, and you clearly want to bring it up there. But right now, we can put this pulse ox on me, and I'm probably damn near 100%.
You 93?
No. I got good lungs. See, only good part of my body left is I got good lungs. My pulse ox, but do I have 100% oxygen in my
only 23%?
Absolutely not.
Right.
Absolutely not. Right. So what we need, they need to be on those high flow reservoir, high flow, delivery devices to wash nitrogen out, and that is not instantaneous. Nope. And I think we often the pulse ox is fine, now we can do we can do the procedure, right? It's like, it was low and we got him to 100, and that's taken me 3 minutes.
The bell curve to that is almost as dramatic as within seconds. I want to say for EMS we consider 2 to 3 minutes you've desaturated to about 80%.
I mean, I'm just thinking early in my career, non-RSI cases, I saw 100 and I was happy, and now I want to attack the airway.
And now you also at that time had the suction running in the corner of their mouth the whole time, which is pulling oxygen.
They've got no reserve, right?
Yeah.
I undertook that, and what happened? Immediately that pulse ox crumbed, right?
Yep.
That was my fault.
And some of these patients, most of these patients don't have normal lungs. I mean, if there's someone with end-stage COPD, I mean, their lungs are not functioning on a great day, or COVID, or bad CHF. So you may get their stat up as high as you can, denitrogenate them as much as you can, and they're still going to plummet very fast. And so the key is just being ready to only take a quick look. If you know that you look and you're like, I'm not seeing anything, and their stat's already starting to go down, don't fool around. Come out and think, what am I going to do differently next time for my next approach? The only thing I can tell you you're not allowed to do is the same thing you did the first time.
I like that.
You have to change something. I don't care if it's a different blade, it's a different operator, it's a different patient position, but the definition of insanity is doing the same thing and hope for different results. So if you go back the same way and expect different results, you're insane.
Ramp the patient. That's one of the biggest things. Yeah. Hyperoxygenate, not hyperventilate. Hyperoxygenate the patient. Ramp the patient to the appropriate position. Be sure that your equipment's ready. Do a quick check. I mean, if you have somebody who you look like it's going to be a Malmapatty 4, it's going to be hard.
Yeah.
We know this.
Preparing your equipment, I think using the checklist is really going to decrease error.
Absolutely.
When you have a playbook and you have a checklist, it's there for a reason. It's structured for a reason, right? So we have good patient outcomes that way. And the other thing, too, we talk about setting out equipment. You have to have a video laryngoscope. So if I have that high Malmapatty score, then and I'm looking at this patient, then my first attempt might be with a video laryngoscope, right? I might be utilizing
you might use a
King
gum
Vision.
elastic bogey.
Yeah, I might use a King Vision. I might use an Air Track. I might use
every
whatever.
cheat.
Yeah,
You
100%.
You cannot cheat in EMS. I tell you, as soon as you get through registry.
You cheat airway, man.
Yeah.
And also part of that protocol aligns is that you have to have a second paramedic with you who is also RSI trained.
Yes.
And this holds you accountable. So hopefully.
And if you're that second paramedic, be a good partner. Like this,
Absolutely.
You may not be the intubator, but they need. I mean, it's a 2-person thing for that reason. You need 3 people there just to make sure, but you just want to make sure you're optimizing everything.
Well, somebody has to bag while somebody's drawing up all these meds, and granted, we have
a
few less with just the rocket, the rocuronium and the ketamine.
And be familiar too. I mean, understand what a non-depolarizing agent is as opposed to a succinylcholine that was depolarizing, and just be familiar with what you're doing and what you're giving. I mean, this is important stuff for us to know.
And you bring up a good point. So rocuronium is non-depolarizing, so you won't see the fasciculations that you see with succinylcholine. So don't also try to intubate too early because you're not going to get a good view. Like it sometimes takes 30 to 60 seconds before the rocuronium is fully working, and you may need to bag them a little bit during that period because they're kind of breathing, but they're not fully paralyzed.
And one of the best ways I think I try to commit it to memory was succinylcholine works on acetylcholine. And so therefore it overstimulates everything. That's why you had the twitching, and then it was almost instantaneous. You could get a view. Like you said, not so much with rocuronium. You'll have to wait for that. So and don't. That's a good time to hyperoxygenate the patient.
Yep.
I'm waiting. Let's just get ready.
You can try to feel the jaw, like okay,
Are we
they are now
loosening up?
paralyzed. They're not breathing. I can take a look.
Yeah.
Arguably, we try to move too fast, and
we do, and that's where I always say slow down.
Slow
down.
Yeah.
But that's the
smooth is fast when it comes to RSI.
The benefit of the paralytic is that everything kind of falls out of the way and they're limp. They're not fighting you. So if you look too early, you're basically trying to intubate a non-paralyzed patient, so you're not doing yourself any help.
There's also a caveat to that, and I've talked about before, but sometimes just giving the induction, the ketamine, is going to be enough. We can stop there.
Yes.
I've got a good view. I don't need to go any further. But again, we might have to re-administer, probably most definitely, when it's time. So just be ready. Watch for those signs you were talking about. Get ready, and have it drawn up. Don't wait till it's too late.
Correct.
And some of the other options too, with moving to this, it's going to make it a lot easier because neither one of these medications need to be refrigerated, right? So rocuronium specifically, when I worked with our pharmacy team members, it actually can come in a pre-filled syringe with 100 milligrams of rock in a pre-filled syringe, and it is good for 90 days outside of a fridge. The vial is only good for 60 days.
So that's great to know.
So specific to us, and we have our pharmacy partners to thank for that. Ketamine, no fridge needed. Rock also is not going to need that fridge. We'll probably be on the vial for a little while, so it'll expire every 60 days. But as soon as we're able to move to rock in that pre-filled syringe, now we're going to move out to 90 days. So it's not going to be that big of a problem for our squads to exchange. Squads don't have to carry special equipment like we kind of talked off camera. We talked about chase vehicles with a refrigerator in it, or squads have to have refrigerators in their squads. Then technically they need to be temperature monitored. You need to be logging those. It adds an extra layer.
But there
of
is
checks that they have to do.
With RSI, true RSI, meaning that we're giving both. With RSI comes special training, so it's not just that it's in the protocol book. It's a free for all. No, this is something that your medical director has come, given lectures, tested people out on this skill, and then you get a certain blessing for certain individuals who pass even a test. And then you have the yearly requirements, which I'm not sure we've even settled all of them yet. I know it's going to require quarterly intubations, live or high-fidelity mannequins.
Yeah, that's a state mandate.
It's a large requirement here, so this is not something you just jump into. There's a lot of training beforehand. So hopefully a lot of this education also comes with how do we store the medication? Where is it stored? It'll be a separate kit, I believe.
Yes.
So
going back to the beginning of this topic, the provider has to be willing to commit the time, but the department as a whole has to be willing to invest because they are investing in the technique. It's going to pay your training time. Having the doc out and having the equipment. There's investment there.
Quarterly updates and refreshers,
correct.
And
that all costs money, and they have to be willing to participate in that.
And then, like I said before, it takes two to tango. So you have to have two who are certified to do this,
Yes.
and the same bus at the same time. So not everybody's going to want to do this.
Yeah, I mean, if you're in a small department, you have 3 paramedics, and the probability of having them in the same place at the same time is non-existent. This probably isn't something to invest time and effort in.
And then also brings up my next point: who are we doing this for, and what are the contraindications to doing it? I mean, you think about, again, like using words like mama patty. What about lug, wedge, angina? Can I RSI this patient? No. So there are caveats to this.
Yeah, you like the indications for intubation is hypoxia that's refractory to whatever else you're trying.
Standard techniques.
Hypercapnia that's refractory to anything that you're really doing, and then impending loss of airway, or they're not controlling their airway right now. And so if you look at that and you think, I can manage this person enough to get them to the hospital, they may not need an airway just yet, and you may give time for things to get better if you've given them other treatments and things. But you mentioned Ludwig's angina. This is where I'm terrified to intubate that patient because, at least with RSI, because they already have a narrowed airway, and when you give them a paralytic, they may fully lose that airway, and no amount of effort is going to get that. And these patients need resources that only the hospital have. They may need a fiber optic awake intubation, or they may need to go to the OR and get stuff that we can't even do in the emergency department. And so you bring up a good point. Just because they need to be intubated eventually doesn't mean it needs to happen right now.
Correct.
I don't know, it was probably 2-3 weeks ago. I was out and about, and I came across another agency's airway kit, and we were looking through, and I opened it up, and what falls in my lap is an old color changer that happened to be expired too, which was funny.
Is an old colorimetric device.
Is an old colorimetric CO2, and I was like, guys, we know that in 2022 you're mandated. You're like, yeah, well, we just have it there for backup.
Yeah, okay.
For backup, fine. I would throw it on the shelf somewhere. But that brings up the again, I hate to come full circle, but we have a state mandate at this point to have waveform capnography. I mean, I remember a decade ago there was just standalone capnometers.
Oh, it's built right into our life packs now. It's going to flash over.
There's a standalone. There's standalone capnometers that just give you a number, but the state is very specific to waveform. That's 2 parts. It's the number and the picture, right? And you have to, we have to now. That's part of our scope of practice. That's no.
It's not an option.
It's no longer a best practice.
And just like our EKGs, those waveforms tell us so much. I can tell you if there's a leak in your cuff. I can tell you if there's they're holding air. I can tell you, and we're not utilizing it enough. And I keep beating capnography like a dead horse, but it's we're not using it enough.
No, I'm the same way too, because we talk about, not to interrupt you, Doc, but we talk about when we move patients, right? So we talk about, we move the patient, we need to auscultate, right? Okay.
What about look at the capnography?
The tube sounds good, right? And then how soon are we going to know, if we want to talk about pulse ox versus capnography, how soon are we going to recognize that I lost that tube, right? Capnography is going to tell me instantaneously. Boom, flat line.
And also,
right?
what did you do in your career before that you changed now? Before, when I intubated, I got the tube in and I slammed every bit of that 10 cc's of air into the tube, into the cuff. Well, how much tracheal trauma was I causing? So now you're looking at your capnography to help be a judge of that too. I mean, how much air should I actually be putting in that cuff?
I mean, you brought up a good point. Like, you cannot fool waveform capnography. Yep. If there is a waveform with every single breath, it's in. Period. End of story. It's 100% sensitive and specific. And then when you're moving the patient, immediately. Because, I mean, the many of the times that the patient would come with an esophageal intubation, I think that it probably happened during moving the patient. I'm sure the tube went in, but then if you lost it when you moved the patient a dozen times through a difficult house and extrication, it's not surprising. But that's why if we have end tidal, we know the second we lose it.
Yeah, 100%. I'm a huge proponent of that. I agree. Our business is moving people. Just like you said, it's whether it's RSI or it's a cardiac arrest and we intubate this patient, it's not on the, ranch-style home with a ramp to the front door. It is going to be in the basement or on the second floor.
Or in the tree house.
Possibly or they're obese. Now we need to carry them. And it's just, there's all those movements for us for the ability to lose the tube, right? Even if we place the proper amount of air in the cuff without hyperinflation and causing any type of tracheal trauma, we have to move them, even slide them over to the bed at the emergency room. There's still more movement, and we need to be checking every time when we move that. Capnography makes it so much easier versus me carrying somebody, and I don't want to auscultate then. No, I want to be able to look at a device, and it's going to tell me right now what I have. Whereas pulse ox, on the other hand, not going to do that. It's going to delay. It's just it'll taper down, but it's a delayed item. End tidal it's a live feed. That's what I teach it. I always say capnography is a live feed of perfusion. That's what you're looking at.
It is.
I like that. That's spot on.
I mean, you could document all the other stuff for tube placement that they have. Nothing over the epigastrium, bilateral breath sounds.
Condensation in the tube.
I don't care if you did none of that as long as you put end tidal CO2. But if you do all of that and leave out end tidal CO2, it's not sufficient.
You can't argue it. It's just
right.
It's so cut and dry. It's easy. It goes with ketamine, right? So for sedating a patient, requirement they need to be on end tidal. So it's like they were perfusing correctly. They were breathing. Or if the respiration rate starts to slow and their end tidal starts to rise, then I know I need to bag that patient and I need to increase the respirations per minute, right? It's just
a great way to treat ICP, and we should be working towards capnography levels in that case. Which also brings me to another question. Debunked myth about rocuronium would be that it increases ICP and that we don't use it with increased ICP.
So I think you're thinking of ketamine in that case.
I'm sorry, ketamine.
Yeah.
So ketamine was thought to do that, and it's probably not the case. A lot of things with ketamine have turned out to not be the case. A lot of the contraindications. There really isn't much other than an allergy. You can use it in most situations. The thing to be aware of is that if you have a patient, I know that one of the side effects of ketamine is increased heart rate and increased blood pressure, but if somebody is agitated or if somebody is about to be intubated and you give them ketamine, it's not going to increase their blood pressure and heart rate. It's still going to drop. It may just drop a little bit less because you basically if you give them ketamine, you've taken away all the catecholamines that they're releasing, and so there's going to be a net drop. So just be aware if you have a patient who has a blood pressure of 70 and you give them ketamine and rocuronium, they're going to die. You have to resuscitate them before you intubate them. So make sure that you stabilize their blood pressure, stabilize their vitals before you push meds, because their pressure will drop and they will unfortunately die in those situations.
That's a good point.
Circling back to the tube placement and waveform capnography, I think it was 2005 when AHA came out and just mandated commercial tube holders, right? Because I certainly remember cutting up IV tubing and shoelaces and staple guns and hot glue and every other way of securing a tube, right? Staple gun, whatever you have, right? But we ad hoc things for so long, and I think in some people's mind, it's like, we're using this commercial tube device, and they're robust. I think most ubiquitously is a Thomas tube holder or a Thomas Select.
It's a great device.
I agree, but often as we were moving people up and down stairs or out of houses, that whole extrication process. Yes, now I have firmly anchored this here, but the end of this tube is still mobile, and when we hyperextend their neck 2 or 3 times as we're carrying them up the
I think hand in hand with intubation, securing the tube should come with a cervical collar. It's just
very reasonable for that reason alone.
Yeah.
And there's a bullet point to that in protocol.
There is.
And Dan's a big proponent of that too.
Yeah, why not keep everything where you left it?
A lot of these unresponsive patients collapsed also and may also have potential C-spine injury that we didn't know about.
Yep.
And why not?
That covers us on the trauma aspect, and then even take it one step further. So we innovate, right? We have all these fancy new technology devices that we utilize. I'll just talk about AirTrack just because that's what my department uses.
AirTrack.
Take a picture. As soon as your intubation is in, tap the screen, take the picture.
I have mine set up at my department.
Put it on the chart.
Put it on the chart right there. Oh, did you get the tube? Pow. Right here.
I have ours set up at our department right now that as soon as you connect the channeled blade, it starts recording.
Yeah, we did record for a while too, and a lot of that I think is good for departments that are going to RSI because this is constant work, right? So we talk about investment, medical director investment, hospital investment, department investment, individual investment. How do we get better? Well, let's watch it, right?
Yeah,
exactly.
So we can watch that video now for training, right? So hey, I had this intubation or I did RSI yesterday. Boom, here's my video.
How many times have I called you to the firehouse to watch a video?
I was about to say this.
And I'm never throwing people into the bus.
You're putting your training videos together, and you even played the one for me, and I'm like,
what are we looking at?
He's like, I intentionally flipped it over, and he's playing it upside down
to see if he caught on to it, and
and it took me a second.
There's the vallecula there, and then
I get it. I just got to look at it,
I do. So one of the ways I teach my paramedic students is I show them a normal sinus rhythm from day one, every day, just like a pathologist would look at a normal cell. And then eventually you throw cancer into it. Eventually I throw an arrhythmia into it. Eventually I show a normal airway upside down. And then all of a sudden it's like, whoa, something's changed. And when you get the mind trained to see something normal so much, and then all of a sudden you throw something odd into it, we look at it and we go, that's an airway? It's oh,
and then you
must to be upside down.
Then you got to start looking at your structures, and
Absolutely.
that's it's like, oh wait, true chords, false chord. Okay, yeah, cool. I had to orient myself. It's like nice trick.
We're both geeks, and
clever,
we just proved that to you guys. Sorry.
Well, that's a good exercise for sure.
It is.
Yeah,
it is. And then when you look at it, and all of a sudden it's so different in your mind, and you're like, at least you've recognized that. Now let's figure out what it is. But
the other one was like, well, what is this? It looks like you're in a forest. It was shag carpet. It was the laryngoscope laying sideways on it looked like it was in a forest. Like, what are we looking at?
Is that a dog?
All right. Any other? I mean, I think we hit all the intubation, the RSI pieces. Anything else about rock that the lack of refrigeration operationally is going to be
That's great.
It's going to be huge.
It's
going to be huge.
Right? I mean, that was really a barrier to entry into the RSI game for a lot of departments because they just couldn't invest in refrigerators.
Labor intensive, monitoring temperature, ensuring that you have a medical grade fridge, B, you have a medical grade thermometer. These temperatures are documented every day to ensure that drug that you're taking care of is going to be effective and is properly stored. So this has really given us a new outlet that's safe. It's going to be stored, and I really like the pre-filled syringe option. I mean, I'm a pre-filled syringe option guy. I like that. It's easier. It takes out an added step. So in my prep, I already know, hey, rock could come in a pre-filled syringe. Not initially until we can get it because of shortages, but as soon as we get to the greener pastures when we don't have any plastic shortages, life will be good. But no, I think it's going to be really nice.
And 90 days is not an unreasonable time to come back. Come back to the hospital anyway. I mean, if it was every month, okay, different set of circumstances. But if you're not burning a drug box in
3 months,
in 3 months, yeah.
Well, and again, I think the departments that will be RSIing are going to be departments that are running a little more than some of the volunteer departments. Not to be blunt, but I mean, if you're running 150 calls a year, you're probably not going to be RSIing.
Right.
Departments that will be are running 1,000 calls a year, so you're at the hospital a lot. I don't think there'll be an issue there.
Yeah, there has to be a comfort level with pharmacology.
Yeah.
Period. When we're taken under an RSI, and there's a lot of meds. You got to be proficient in those micro skills of just drawing stuff up and getting it delivered correctly to the patient. So, all right. Anything else? All right.
I don't think so.
So what are take home points for the RSI?
That there is many contraindications to succinylcholine. There's only one to rocuronium, which is an allergy. You need to resuscitate patients before you decide to intubate them. Make sure their blood pressure is good. And then I would say if you're going to push a paralytic, you have to be ready to potentially do a surgical airway because all difficult airways end with a surgical airway.
Yeah.
All right.
Excellent.
Fantastic.
Thanks for joining us.
Yeah, well, yeah.
My pleasure. Thanks for having me, guys.
That was good.
Yeah.